Hello, everyone. Hello.
Hello,
Hello
yes, sir.
there.
Yes, Assalamu alaikum, sir.
Walaikum assalam. How are you doing all?
Alhamdulillah, good, sir.
Very doing well. How are you, sir?
I'm good. Thank you.
You're welcome.
So, I was interested in asking that how many of you have gone through nephritic and nephrotic syndromes? Our
I
today's
have,
topic.
I have to.
I have done, sir.
Yeah. So, actually, today's topic is for most of the students, it will be very easy. All the students, those who have studied it, will feel it very simple. And because in nephritic and nephrotic syndromes, you will have the high yield points, the pathognomonic points, and you will easily be doing your questions. But if any one of you or any students who does not have revised the topic, it will feel difficulty. Okay, so don't worry, it will be an easy one. You just have to know the important high yield points about specific cause of nephritic or nephrotic syndrome. Right? So we
Okay,
should
sir.
start. Which is okay. So is my screen visible?
Yes, sir.
Okay. So anyone who wants to start?
I can.
Okay,
Which
please.
having additional finding is most likely to be seen in the patient. 3-month-old brought to the office due to fussiness, poor weight gain, and polyuria. Urine volume is 700 to 800 ml per day. The patient's maternal grandfather has polydipsia and polyuria. Serum sodium is 151. Genetic testing reveals a vasopressin 2 receptor mutation, which is the following additional finding is most likely to be seen.
So I think it's an easy question. We have a 3-month-old boy
Yeah.
with polyuria and poor weight gain, right? We have the serum osmolarity, which is above normal. 140 is normal, right?
Is
And
that nephrogenic insipidus?
sorry,
Is that diabetes insipidus?
yeah. So we have the problem we have is in V2 receptors mutation, right? So simply we can say that ADH that works on V2 receptors are not able to perform its function because the receptor is mutated, right?
Yeah.
So they have already given you serum osmolarity, right? And they are asking about what are the findings. So serum osmolarity they have given you, which is high, right? And you can also see if we are not reabsorbing water, so which means losing water, right? Losing water. By losing water, the serum osmolarity will get increase, right? So we have high serum osmolarity. Sorry for we didn't diagnose first. One of the student was saying it is diabetes insipidus, right? Diabetes insipidus are of two types. Anyone?
Central and
Nephrogenic.
Yeah,
cent-
central and nephrogenic.
nephrogenic.
Central, central we don't have ADH, okay?
Yeah.
And nephrogenic is our case.
Due
ADH
to
is present.
receptor
ADH is present, but don't
receptors.
work because of the receptors problem, right?
Yeah.
So if we are losing more water, what would be the osmolarity of urine?
Increased.
Low.
Sorry,
Low,
low.
right?
Low.
To be decreased.
Low.
Because water is high, right?
Dilated.
What are they saying in desmopressin? Desmopressins is ADH
ADH.
analog, right? So
Mm-hmm.
in central uh, diabetes insipidus, we don't have ADH. When we provide ADH, we will start resorbing water, right?
Yes.
And in our case, in our question, we have ADH, but the receptor are mutated. So by giving desmopressin, there won't be
Exactly.
any change, okay?
Mm-hmm.
So this is the basic difference between central and nephrogenic. In central, if we provide ADH, the functions will normalize, okay? While in nephrogenic, the ADH or desmopressin provided will not be functioning, right?
Mm.
Yeah.
Got this?
Yes.
Yes.
Mm-hmm. Yeah.
So what's your answer?
Um,
A.
A.
Yeah. So we have our first answer done.
Justify.
Yeah, and one other point over here is I would like to mention is primary polydipsia. So in central diabetes insipidus and nephrogenic, we are polyuric, right? We are producing more urine in both cases, right?
Yes, sir.
So what is primary? In primary, we have something like um, psychiatric disorders where we drink more, okay? Got this?
Yes.
So what is water deprivation test? Water deprivation test will tells you whether it's a primary polydipsia or diabetes insipidus. How? Anyone knows this? Water deprivation
It-
test?
With water deprivation test, if it's a primary polydipsia, then there will be concentration, so the serum osmolarity
Yeah.
will increase, unlike in nephrogenic or whatever diabetes insipidus.
Yeah, so our ADH in primary polydipsia, ADH is normal, receptors are normal, just we are drinking more water, right? That's why our urine osmolarity becomes low, okay? So if we deprive the person from water, the physiology will gets back normal, okay? Got it?
Yes.
Okay, anyone please? Be quick, guys.
Okay,
Which
okay.
of the
Which of
following
the
is the
following is mostly which of the following is most likely cause of this patient condition? A 12-year-old girl is brought to the clinic by her parents after she is found to have a hypertension by her school nurse. The patient has no symptom and read books during the office visit. Her family immigrated to United States 2 months ago and she has not received routine well child care. The patient has had several episodes of fever and abdominal pain, and which her parents treated with over-the-counter antibiotic available in her country of origin.
Blood pressure is elevated on several readings in the office. There is no family history of hypertension. Renal ultrasound revealed dilated calyces with overlying cortical atrophy bilaterally, mostly in the upper and lower pole. Which of the following is most likely cause of this patient condition?
So, what do you understand from the stem that we have? A girl, okay?
Yes.
So, I have discussed with you posterior urethral valve. It is only for boys, okay? You know this, right?
Yes, sir.
Yeah.
Yes, sir. Yeah.
So, you have to make the question easy for yourself just by looking at the high yield points, okay? So, and she has recurrent episodes of fever. What else she have? She have blood
The-
pressure elevated,
Yeah, and
okay?
hypertension.
Yeah, so she has hypertension, dilated calyces. What is this? When is,
Hydronephrosis.
yeah, so we have discussed the bilateral and unilateral hydronephrosis, and hydronephrosis is because of something that is obstructing the urine flow, right?
Yeah.
And we have cortical atrophy. So we have something like chronic
Kidney
kidney
failure.
injury, right?
Yeah.
Yeah.
Now come to the so what are they asking? Which of the following is most likely the cause of the patient? So we have autosomal dominant polycystic kidney disease. So first thing is that autosomal dominant is in youngers, right? We can say adults.
Yeah.
Okay.
Yeah.
And we don't have cyst, right?
No.
In our stem, we don't have any cyst.
Yeah.
So the other thing we have is multicystic. So we can exclude both, right?
Yes, sir.
And we have excluded posterior urethral valve because
It's a girl.
it is only to
Female.
boys.
Yeah.
Mm-hmm.
What about malignant hypertension? Malignant hypertension will cause the problem acutely. Okay,
Okay.
it will affect organs, specifically kidney, acutely, right? When we
Yeah.
have very much raise in blood pressure, the effects are sudden. Okay,
So
we
it
will
has to be a
discuss.
very high blood pressure, right, sir?
Yeah,
Like in
yeah,
the 300s, maybe?
yeah, yeah. I don't know what's
Or
the.
up.
I think it's more than 170 or
Two.
180.
Okay.
Okay, we will
Okay.
discuss the hypertensive urgency, hypertensive emergency. Okay,
Okay, sir. Thank
so we
you.
will discuss these hypertensions. Okay, so what do
Okay.
we have is reflex nephropathy. Okay,
Nephropathy.
and we
Yes.
have discussed that the ureters are abnormally inserting, right,
Dilate. Yeah.
and which is causing the backflow, right?
Confusion. Yeah.
So these were I think the questions from the previous classes. Most of the questions today are from nephritic and nephrotic. Okay,
Okay, sir.
anyone, please?
Which of the following is the most likely additional finding in this patient? 26-year-old woman dies shortly after sudden onset severe headache. She was recently diagnosed with hypertension but otherwise had no medical problems. The patient was a lifetime non-smoker and didn't use illicit drugs. Autopsy reveals evidence of intracranial hemorrhage. Both carotid arteries appear tortuous distally with alternating areas of fibrotic webs and aneurysmal dilation. On microscopic examination, the aneurysmal segment of the carotid arteries lack an internal elastic lamina. Which of the following is the most likely additional finding in this patient? Adrenal tumor, coarctation of the aorta, hypertrophic cardiomyopathy, renal artery stenosis, thyroid follicular hyperplasia.
So, what do you think? What's the problem occurring here?
The increased blood
Hyper-
blood
Blood
that
pressure.
may be coarctation due to coarctation.
Sorry.
There's
uh,
actually
so the
Yeah.
so the patient had like a stroke, um, severe
Mm.
headache, then most probably have a aneurysmal disruption,
Yeah.
and Yeah, she found to have also carotid aneurysm,
So,
dorsal
so, so we have intracranial hemorrhage because of aneurysm, right?
Yeah.
And carotid artery is tortuous, okay, fibrotic, also have aneurysms, okay, and we have lack of internal elastic lamina.
Is this fibromyalgia?
Yeah.
Yeah, you are almost there. Fibromuscular
Just
dysplasia. So
Yeah,
we
usually
have
associated with renal artery,
fibromuscular
associated with
dysplasia.
renal artery
renal
stenosis.
artery stenosis.
Yeah, so we have discussed the renal artery stenosis in we had a question, right, yesterday. So the
Yeah,
causes,
increased renin, I think, in that.
yeah.
Yes.
So what are the causes of renal artery stenosis? Anyone? Atherosclerotic plaques, and so these two are the most high yield causes of renal artery stenosis. Okay, they will be in older
Males,
people and this will be in
young
younger.
people,
Okay, so we have
young women.
so we almost got our answer because we have fibromuscular dysplasia and we have a young 26-year-old woman, right?
Yeah.
And the important point over here is lack of internal elastic
Yeah.
lamina. And because of the fibrosis over the blood vessels, in the blood vessels, we develop aneurysmal dilatations. Okay. So if we look into the other options, most of them can cause hypertension, okay, like adrenal tumor, coarctation of aorta, hypertrophic cardiomyopathy, and thyroid follicle hyperplasia, but none of them will cause aneurysmal dilatations, okay. So these are the pathognomonics for fibromuscular dysplasia, and we will discuss the fibromuscular dysplasia in some other class if you guys want. But I think the high yield points over here are we should know that fibromuscular dysplasia is causing renal artery stenosis in youngers, and plaques are the causes of renal artery stenosis in
Older
adult and older.
patient.
Okay,
Okay.
so we have renal artery stenosis. One other MCQ I have seen that what will happen when we have unilateral renal artery stenosis? What happens when an artery do not receive blood?
That will atrophy and we
Yeah, so it is
will get kidney.
it is getting atrophied. It is very high yield, okay?
Okay.
And you guys also know the physiology behind the blood pressure, okay? GFR, right?
Yes.
How the GFR is decreasing. So I think from renal artery stenosis, if you know all these points, it's enough, okay?
Yeah, this also says that there's also intracranial hemorrhage. Is that like
Yeah.
a distractor
So
or why is
all
it
of
there?
these are because of aneurysmal dilatations, okay?
So
What is
how do we differentiate this with coarctation?
yeah,
Like,
so we will discuss coarctation in detail, but
okay.
I guess the buzzword will be given because there will be difference of blood pressures in the
Ah, okay. For
yeah, so
coarctation, right?
yeah,
Yeah,
for
I understand.
coarctation we have the difference in blood pressure, right?
yeah.
In
Okay, so they have to give that,
different
right? So we think,
yeah, so
big,
this one also be given, and the most high yield over here is the aneurysmal, okay, dilatations. Okay, it is aneurysms are also present or in the cranium, right? So
yes, sir, yeah.
in
So
coarctation of
like the
aorta we
berry
don't have
aneurysm.
that. Okay.
Yeah.
Okay, okay, okay. Thank you.
Yeah.
Thank you all.
Okay. So Uh, we will do this. It's an easy question about the kidney stones. We will do it tomorrow, okay?
Yeah.
You know that it's the cystine
The C-
picture and yeah.
Yeah, hexagonal structure. Yeah.
Yeah, and we have discussed this almost a minute ago. Anyone, please?
The patient most likely suffers from which of the following conditions? A 62-year-old man comes to the office due to poorly localized intermittent abdominal pain that is triggered by eating and slowly subsides over ensuing several hours. The patient has also lost 4.5 kg over the past 2 months. He has history of hypertension and hyperlipidemia and has smoked a pack of cigarettes daily for 40 years. Blood pressure is 175, 105, and pulse is 70. And regular abdomen is soft, non-tender. CT of the abdomen reveals renal findings shown in the image. What is the following condition patient mainly suffers from?
So,
The triggered by eating. So that's
so
peptic ulcer that is triggering by eating, something like that.
sorry.
This so renal artery stenosis and the cause is plaque, atherosclerotic plaque.
Yeah, so we have to look over to the risk factors of plaque. What are the risk factors? Age, right?
Mm.
And where is it? He has been a smoker for how long?
Years.
Sorry,
Mm.
he has history of hypertension,
Of
right?
hypertension.
And hyperlipidemia, right? And
Yeah.
Yeah.
smoked pack of cigarette for 40
For
years. So all of these are the risk factors of atherosclerosis, okay?
Atherosclerosis.
And the other confirmatory sign is he has abdominal pain
pain.
by triggered by eating. So it is more of the mesenteric ischemia, okay?
Oh,
If you don't know all the details in a STEM, don't worry because they will give you some of the high yield or some of the pathognomonic signs that you will get your question, okay? So
okay.
blood pressure is elevated, right?
Yeah.
And the abdomen is soft and non-tender, which means we don't have any obstruction, etc. Okay.
Mm-hmm.
So what does the CT scan reveals? This is the right, this is the left. Left kidney is
Atrophy.
Smaller
Smaller,
atrophied.
atrophy.
atrophy.
So we have all the risk factor of atherosclerotic plaque, right? And
Yeah.
Yeah.
atherosclerosis causes renal artery stenosis in
Mm.
adults, and we have 62 years of age. Okay.
Age. Yeah. Okay.
So what's our answer is renal artery stenosis.
Stenosis.
So I would like to briefly go through the other questions. We will discuss it again and again in coming classes. Okay, we don't have discussed this and this. Okay,
Okay, sir.
also we don't have done. If they have been done in previous classes, you would know. But I think tomorrow will be the interstitial diseases. Okay, but I would like to discuss that some high yield points that in pyelonephritis we will have. We were right. Glomerulonephritis, we have hematuria. We have discussed the hematuria part, right? You know this, right? So in our stem,
Yes.
we don't have such sign and symptoms. Okay, we will
No.
have microscopic hematuria. Amyloidosis. I would like to discuss this in great detail because we will have some questions over it. But I think you guys know that amyloidosis causes which disease? Nephrotic, right?
Nephrotic, yes, sir.
And anyone who would like to tell me what is amyloid protein?
That is beta, like misfolded proteins.
Misfolded proteins, right?
Okay, so any protein which is in beta pleated form, okay? Normal we have like this, right? What is this called? I forgot. So normal our proteins are in which shape? And the beta pleated are like this, okay?
Yeah.
So I think they are more globular or something, okay? So if any protein due to any reason got beta pleated or we we will say it's an amyloid protein, and when amyloid deposition occurs, we call it amyloidosis. Okay.
Okay, sir.
So what does it cause? Nephrotic syndrome.
Nephrotic
And
syndrome.
I'm going to discuss the amyloidosis in great detail in coming questions. Okay.
Okay, sir.
Similarly, hemolytic uremic syndrome. uh, okay, we'll discuss this after. Okay. I
Okay.
don't want to go jump over here and there. Okay.
Yeah.
Yeah, and this one, myeloma, um,
Oh, yeah. My,
multiple
myeloma.
multiple myeloma would also lead to increased proteins. Okay, that are I think kappa and lambda, right?
Yes, sir. Light chains
Light chain protein, yeah.
protein.
So the these protein also get beta plated, okay, and
Okay.
will cause amyloidosis. Okay, so it's
Okay.
one of multiple myeloma is one of the cause of amyloidosis. Okay. So from picture and from our stem, we have almost uh, 90 to 100% we have understand our question, right?
Yes, sir.
So anyone?
Which of the following histologic abnormalities is most likely to be seen in this patient's glomeruli? A
Yeah.
64-year-old man comes to the office due to generalized edema, fatigue, and dyspnea on exertion for 2 months. The patient has a 25-year history of poorly controlled rheumatic arthritis. Temperature is 36.9 Celsius, blood pressure is 108 over 70, pulse is 90 per minute. Patient is thin and appears chronically ill but is in no acute distress. There is no lymphadenopathy. Breath sounds are decreased at the lung bases. Musculoskeletal examination shows severe deformities of the hands and feet related to rheumatoid arthritis. There is pitting edema of both legs up to the knees. Peripheral pulses are normal. Urine analysis shows 4 plus protein but is otherwise normal. Renal biopsy is performed. Which of the following histologic abnormalities is
So
most likely to be seen in this patient's glomeruli?
so what are they? What they have given us that he has nephrotic range of
Syndrome.
proteinuria, right?
Yes, sir.
And he has chronic inflammatory sickness,
Inflammatory
right?
disease. Yeah.
So I would like to go to question number 10. I
Okay.
have marked these for you guys so that these
Mm.
questions are somehow related.
Oh, that's
So it
great,
will
sir.
be
Yeah.
time. We will have some. Yeah. So you were discussing amyloidosis, right?
Yes, sir.
So what are the causes of amyloidosis? We have discussed that what is amyloid protein, right?
Yeah.
So plasma cell dysgenesis, or we can say multiple myeloma, will cause light chain protein to be increased, right?
Yes, sir.
And we will have what?
AL type amyloid fibrils.
Yeah. So first cause is multiple myeloma, or we can say plasma
Myeloma.
cell dyscrasia.
Dyscrasias.
The second thing is chronic infections or inflammation. So we
Uh,
can say chronic. What do we have in our stem? Rheumatoid arthritis.
Rheumatoid
Okay,
arthritis. Okay.
and TB. Okay,
TB.
what will they do? They will
Chronic
increase.
inflammation.
They will increase amyloid
A protein.
serum amyloid A protein. Okay.
A protein serum amyloid.
The
Okay,
third
sir.
one is in elderly men, we see transthyretin increase. Transthyretin do that it transport thyroxine, okay,
Okay.
and the accumulation of transthyretin will do what? amyloidosis. Okay,
Okay.
so we have the mechanism is almost the same. Okay, the
Okay.
proteins are increased, they got beta pleated, we can say abnormally, the shape become abnormal. Okay,
Oh yeah.
so we got amyloidosis. Okay, and also in stage renal disease we have beta 2 microglobulin. Okay, they are increased, they have given the reason because they are decreased clearance because of renal disease, right? CKD.
Yeah.
So we don't clear this out. So we have amyloid beta 2 proteins, okay, accumulation. So all these are the causes of systemic amyloidosis. You guys will have to remember all the four causes, okay? First is
Okay.
multiple
First is
myeloma.
multiple myeloma.
The second
Second is
is chronic
chronic
inflammation and infections like TB and
infection,
rheumatoid.
arthritis.
The other is transthyretin, and the last one is beta 2 microglobulin because of decreased clearance. Okay, so let's come back to our question. Which one was this? Five or six? Well,
Yes,
six.
sir.
So, what do we have? Rheumatoid arthritis,
Chronic
inflammation,
inflammation,
chronic inflammation leading towards nephrotic syndrome. Okay,
nephrotic syndrome. Yeah.
so it is accumulating in kidney, right?
Yes, sir.
So, what will we see? Renal biopsy is performed.
B. Amorphous material.
Yeah. So amyloid is an amorphous protein. Okay.
But okay.
So, what
Tumor.
about the crescent formation? Where do crescents form?
Rapidly progressive glomerulonephritis.
Rapidly progressive
Progressive
glomerular.
glomerular.
Yeah. So these points you guys should memorize it. Okay.
Okay, sir.
But I would give you some hint or some concept that why we have crescent formation in rapidly progressive glomerulonephritis. Okay.
Yeah, but there are so many more diseases associated with RP gene, right, sir?
Yeah.
Which we will also have to remember.
Yeah. We will discuss RPGN in great detail. Okay.
Oh, that's wonderful. Thank you,
But
sir. Yeah.
what happens is that the basement membrane got ruptured. Okay. And
Okay.
all the cytokines or inflammatory cells and macrophages, neutrophils, immune complexes, all leaks through the filtrate. Okay, and
Okay.
what will cause this that it it is forming a crescent. Okay, crescent is like a moon shape. So we have lots of different cytokines, inflammatory cells. We will have increased hypercellular. We will have hypercellularity, and we have most importantly we have here a fibrin, right?
Yes, sir. Yeah.
Make me correct if I make some mistakes. These are the the points are being memorized. Okay,
Okay.
so
No problem, sir.
so it forms a crescent. Okay, so
Crescent, yeah.
how will you remember the crescents to rapidly progressive? When the crescent is formed, the GFR gets very much decreased. Okay,
Decreased. Okay.
and it why it is decreased? Because the crescent does not let any filtrate go through. Okay,
Okay, sir.
so this point is for memorization, that when
Okay.
crescent is formed, GFR is severely decreased,
Decreased.
and we will rapidly progress to end stage renal disease. Okay,
Okay.
got this?
Yes, sir. Yeah, got it. Okay.
Sir,
Yeah,
how to differentiate from the point C like diffuse hypercellularity? Because most of these glomerular diseases, like they have this inflammation, cytokine release, and
yeah, yeah,
hypercellularity. So this kind of like a mixed picture. So how can we differentiate point C from the B if
yeah,
in context of we thinking about chronic infection, not
yeah.
exactly about amyloid?
So
Can
let me give you a concept of what is happening in how is hypercellularity occurring. Okay, so we have post-streptococcal glomerulonephritis, right?
Yes, sir.
We have hypercellularity, right?
Mm. Mm. Yeah.
What other conditions have hypercellularity? D, E, G, N, right? Diffuse,
Proliferative.
proliferative,
Proliferative.
glomerulonephritis. What was the third one? Yeah, so I would write we don't have hypercellularity in membranous, and the other one is membranoproliferative, right? MPGN, right? So I would like to explain that most of the high yield points are within the name of the disease. Okay,
Yes,
we
sir.
have
Okay, sir.
why we call
Yes,
it
yes, sir.
diffuse.
Like
Because
it
it's
involve more than 50
all over the
50%
place.
involvement.
Yeah, so if we have a kidney and we have like this much of the nephrons, so all the nephrons are, we can say more than 50% of the nephrons are involved. We call it diffuse, okay?
Diffuse. Okay.
But if in a kidney we have four nephrons and part of the nephrons are involved and all the nephrons are involved, what we call this? It is diffuse, right? All the nephrons are involved, right?
Yeah.
But parts of the nephron are involved. What will we call it? Segmental, okay?
Focal segmental.
Mm.
Got it?
Yes.
Focal, segmental, okay? It will be focal if we have one, two, three, four. If we have two involved, sorry, if we have two involved and two are parts of these two are involved, so it is not diffuse, right? It is focal, okay?
Okay.
And segmental, okay?
Okay.
What about if we have a kidney and we have all the four involved and all the four are completely involved? So completely involved, we call it diffuse,
Diffuse.
okay? But all are completely involved. We call it global,
Mm.
okay?
Okay. Okay.
So diffuse versus focal, okay? And global versus segmental, okay? If some part of the nephron is involved, it is segmental. If all the nephron is involved, it is global, okay?
So diffuse
Okay.
and global are pretty much the
Yeah,
same thing you're
yeah, I'm
saying?
explaining it, okay?
Okay.
Sorry, sorry for confusing it. So, what is segmental? If a segment of the nephron is involved, okay? Like
Okay.
some nephron have the basement membrane and the glomeruli of the some nephron are involved and some are not involved, okay? We
Okay.
call it segmental. And if some nephron are involved, we call it focal, okay? What is global? If all the nephrons are involved, okay? Don't confuse it number and whole, okay? If all the numbers are involved, we call it global, okay? Sorry, if all the numbers are involved, we call it like
Diffuse.
four. We have four, all the four are involved, we call it diffuse, okay? But the whole parts are involved, we call it global. We will you will understand it with the coming question where we discuss focal, segmental, glomerulonephritis, and all these, okay?
Okay.
So What was the question? What were we discussing? Yeah, hypercellularity. So
So these are the four conditions that would cause hypercellularity, right? So you said
no,
post-streptococcal glomerular
in membranous we don't have hypercellularity. Okay,
cellularity.
the
Okay.
cellularity will be represented by the name which will be saying proliferative. Okay,
Oh, okay.
so whenever we see proliferative, we have the cells are increased. Okay,
Increased. Okay. So MPGN also
so
same, right?
yeah, so
It's
it is membranoproliferative.
proliferative.
So why I wrote this membranous versus this? If we have the basement membrane involved, we call it basement. Sorry, if the basement membrane thickness is increased, we call it membranous. Okay,
Membranous. Yeah.
without without
Proliferation.
proliferation or hypercellularity. Okay,
Hypercellularity. Okay.
when no hypercellularity and just the basement membrane thickness is increased, we call it membranous. But if
Membrane.
we have the increased thickness of the membrane along with the proliferation, what we call
Then
it?
MPGN,
Membranoproliferative
membranoproliferative glomerulonephritis.
glomerulonephritis. And one other condition that causes proliferation is post-streptococcal
Glomerulonephritis.
glomerulonephritis. Okay.
Okay.
So what is IgA deposition do?
In Berger's disease, right?
Yeah.
It's
So
nephritic syndrome.
yeah. So we have PSGN, post-streptococcal glomerulonephritis, and Berger's IgA. What's the difference between these? Both of these are after infection, okay? Both
Okay.
of these are after infections, okay?
Okay.
This is the first point. But you will have you will have to differentiate based on the time. The first one will be in weeks. After
Okay.
2,
The
3,
infection.
4 weeks infection, you will have post streptococcal glomerulonephritis. Okay. And
Okay.
what about IgA?
It's
It
one.
will be after upper respiratory infections and diarrheal. Okay. Infections,
Oh,
and it will be days
oh,
after this, 1 day, 2 day. Okay. You will have
okay.
IgA nephropathy. What's the other difference is in post-streptococcal glomerulonephritis and this? Why do we have immune complexes formed? So this concept is based on the type of hypersensitivity. Okay,
Hmm.
so we have all of us know we have how many type of hypersensitivity?
Oh,
Four
Four.
types.
sorry.
This concept is very important. Okay,
Okay, sir.
just understand the simple concept and you will be easily picking the questions. Okay, so if we
Okay.
have IgE, we will have type
One hypersensitivity.
One
1 hyper.
hypersensitivity.
IgE is exogenous. Okay,
Okay.
always cause will be always exogenous, like in asthma,
Allergies.
etc. Okay, allergies.
Okay.
Okay,
Okay.
so type 1 hypersensitivity reaction or to the antigens is the antigen will always be exogenous. Okay,
Okay.
what about type 2 hypersensitivity? Type 2 will be Ig, G, and M. But
Hmm.
what's the difference here? That the antigen will be endogenous. Okay, got this? So if anyone can give me the example of endogenous related to the kidney, endogenous
Good posture.
anti. Sorry.
Good posture.
Yeah, great, good pasture.
We have antibodies against the basement membrane.
So we have the basement membrane type for collagen. Okay, basement membrane. So we have the antigen which is type for collagen. The antigen is endogenous, okay?
Okay.
So what is type 3?
That's complement.
When what?
Complement
Any?
action.
Immune complex.
Immune
Yeah, immune complexes are formed, okay? So immune complexes are formed when the antigen is present in blood, okay? So when antigen is present in blood, we have antibody reacting to it. We form immune complexes, and these immune complexes travel to lodge into kidneys, okay? So I was, and what is type 4?
delayed type of hyper.
Delayed type hypersensitivity.
Delayed, and it is because of cellular cell mediated, right?
Yeah,
So
sorry.
I am discussing all these because we have immune complexes forming in post-streptococcal and IgA nephropathy. Okay,
Okay.
why are these complexes formed? Because we have antibodies. Okay, against what? Against infective like microbial antigens. Okay,
Okay.
so they comes into blood and antibodies are formed against it. So which type of hypersensitivity we will see?
3.
Type 3. Okay, got this?
Type 3 in both, right? IgA2, right?
Yeah. So why is this important? Because the immune complexes, the first thing is we know the type of hypersensitivity. The other thing is the immune complexes are forming outside the kidney, right? And they are in larger size, okay? So when we have larger size deposition, anything which is
Immune
larger
complex.
and yeah,
Yeah.
immune complexes which is larger, so it will deposit in endothelium, okay? You know
Oh,
this. We have first
endothelium.
we have endothelium,
Yeah.
then we have basement membrane, and then we have photocytes, right? So
Yeah.
this is the first component that will be in contact to blood, okay? So the other differentiating points here are in post and PSGN, post-streptococcal, we have deposition in subendothelium, okay? While in IgA, it is
Mesangium.
in mesangium, okay? And mesangium is, we have the basic structure like we have this blood vessel, this is endothelium, okay? This is the basement membrane, okay? And we have the photocytes. This is the mesangium, okay? So you guys know how well we will differentiate the IgA and
PSG.
post-streptococcal, right?
Yeah.
So this is the easy concept, okay? But one important thing over here that in immune complex deposition, we have granular immunofluorescence, right? The granular The granular is, we simply can say that it is not uniform or not linear, okay? The deposition is not linear,
Linear
and it is because of type 3 hypersensitivity forming immunocomplexes.
complexes.
But what happened in good pastures?
We have
What
a
type of hypersensitivity was it?
type 2.
Type
So what happens in type 2? I have told you in type 2 we have
Endo
endogenous
antigen.
antigen, and we have in, if this is the basement membrane, so we have type 4 collagen present like this, okay, uniformly, okay.
Okay.
The type 4 collagen is present uniformly, and the antibodies because of type 2 hypersensitivity, it comes and uniformly deposit over it, okay? So in Burgess, we will have linear immunofluorescence, okay?
Okay.
And in post-streptococcal glomerulonephritis and IgA, what it will be?
Granular.
Granular, okay? What about type 4, like in vasculitis?
There will be no immune complex. It will be posse immune.
Yeah, so we don't have antibodies, we don't have immune complexes, so we call it negative or
Protein.
posse, posse immune. So you know that the immunofluorescence concept, that why is it granular, why it is right, it is linear, and why it is posse immune, right? Anyone have any confusion?
So just a quick question. In case of immunoglobulin A nephropathy, you said that there will be immune complex deposition and there will be type 3 hypersensitivity.
Yeah.
Okay, okay. Just I was just clearing that.
Yeah,
Thank you, sir.
so the difference was that in I post-streptococcal it is subendothelial, okay?
Some
And and IgA we have
epigens.
Messenger.
Mesangial.
mesangial, okay?
Okay, yes, sir.
So it's a type 3 hypersensitive, right? You're saying IgA?
Yeah, I think so if I'm not wrong. You can verify it if I'm
Okay.
wrong, okay?
Okay. Okay, sir.
Okay,
And
and
then post-streptococcal is what type? Type 3 also, right?
yeah, so some books write it like the type 2 is then changed to type 3, okay?
Mm.
And how is the type 2 occurring, that like same like this one, the
Okay.
antibodies react with, some of the antibodies react with the basement membrane, so it is type 2 as well, okay? And the immunocomplexes forming are type 3, okay?
Oh.
So the important or you for you to remember that
Mm.
PSGN is type 3, okay?
Type 3. Okay, sir.
So
Thank you.
what about good pastures? Good pastures we have linear, okay?
Yeah, Lily.
But in Alfers, you know this, in Alfers also type 4
Type 4
collagen,
What is that?
collagen, type 4 collagen is
Ah,
affected,
type
right?
4. Yes, yes, sir. Yeah.
And same
Good
basement
posture.
membrane, but we don't have
antibodies.
we
Here.
don't have antibodies. It is mutated, okay?
Yeah.
So don't confuse the type 4 collagen of good pastures with Alfers, okay?
Yes.
So in Alfers we have mutated, okay? And the basement membrane is weak, okay?
Mm.
So if the basement membrane is weak, we say that we have splitting of basement membrane in Alfers, okay?
Okay, sir.
So
So we don't have splitting in Alberts, we have splitting in the MPGN. In Alberts, actually, we have the irregular thickening that actually forming the basket weave appearance.
yeah, so we also have splitting. If you look into your first aid, I have first aid saved for you guys
Yes, there is a
for
splitting of the
for
GBM written
discussion.
in first aid.
I have saved this because today's topics, all the points were of like ratta. You have to memorize it, okay? But I am trying to give you some concept that you remember some of the things, okay? We have ulcers, okay? What do
Yeah.
we have here is splitting of the
Yeah, there's thickening and splitting.
Splitting of the
Maybe.
GBM, okay? What I'm gonna do is let's have a quick look through these so that the coming questions will be very much easy for you, okay? Yeah, so what we have discussed that it is PSGN, right?
Yes.
Yeah, and what one important thing about PHS is we have streptococcal, right? And
Yeah.
what is the bacteria?
Beta hemolytic group is streptococcus.
Which group?
Beta hemolytic. So as
Yeah, and in beta hemolytic, which group was this?
group A, sir.
Yeah, so we have strep pyogenes, okay? And I think Dr. Ali have done the session on strep pyogenes with you, right? Have you done
Yeah.
with it? So in strep pyogenes, we have pharyngitis, right? We have impetigo, right? You know this?
Yes, sir.
Yes, sir. Yes,
Okay,
sir.
and what's in herd? Jones criteria we had, right? So it can cause,
Joint pain.
I think mitral regurgitation was there, right? Was it mitral? I forgot the micro, okay? That's why I have given it to him. So I'm saying, what I'm saying is the strep pyogenes is causing the problems over here, okay? So in some question you will see that we have problem in herd, okay? We have skin problem like impetigo, we have pharyngitis, and they will ask you about what will be the mm, immunofluorescence, what will be the electron microscopy, or simply they will ask you what's the disease, okay?
Yes,
Got
sir.
this?
Yes, sir.
So most of the students remember that it is uh, post infection, but you guys have to remember the hurt, you have to remember the skin, the pharyngitis, you have to remember the strep pyogenes actions, okay? They will give you the high ASO titer, all these stuff, so that you can got the point that the bacteria is strep pyogenes, okay?
Yes, sir.
What other we have discussed that hypercellularity is present over here, okay? And it is um,
Yes.
deposition along
Sub epithelium.
GBM. Some of in previous books we don't have the mesenterium mentioned in previous first aids, but they have given it in mesenterium also, okay? And the subepithelial humps are because of type 2, okay? But it is not important, these things are not that much important, okay? Like you have to remember why it is because of type 2, 3, just you have the
Overall.
major concept, okay? So that you can pick the question, okay? The starry sky appearance is important, lumpy bumpy, okay? Because of the gran- granular appearance, starry sky, lumpy bumpy, because of immune complex deposition in non-linear fashion, okay? And we have decrease complements, okay?
Yes.
I think they didn't have mentioned here, but it is important, okay?
C3.
Yeah, so you know post-streptococcal now, right?
Yes.
What is IgA nephropathy? We call it Berger's. We also call it Berger's. Yeah, Berger's. Yeah, it is upper respiratory infections and GI, okay? Why it is GI? Because IgA is mucosal, present on mucosal lining. That's why we have respiratory and GI infections, okay? Because we have the same mucosal lining, right?
Yes.
Yeah, so what about the others? Rapidly progressive glomerulonephritis. So I have told you how to remember this. Because of the crescents formation, we have decreased, very much decreased GFR, and it is rapidly going to end stage renal disease. That's because of this simple concept, you will remember rapidly progressive is crescentic. Okay, got this? I will
Yes,
show you the crescent picture and you will understand how the GFR is decreased. Okay, got this?
yes, sir.
In good pastures, why it is type 2?
Because of the antibodies against the
The
G
the the antigens were the antigens were
endogenous.
the antigens were not in the blood, okay, and were endogenous, okay. So they are not forming immune complexes, okay. What will be the pattern? Linear, okay. Got this?
Yes, sir.
In good pastures. Yeah, what else? Yeah, and the fibrin is important in crescents. Okay, all this inflammatory cells like monocytes, neutrophils, complement systems, all will be there. But the fibrin is what causing crescents. Okay, they all combine form crescents. Okay, what else we can say? Yeah, monophages, linear immunofluorescence. I have explained this. Okay, negative post-immune. Why is it negative in vasculitis? Because it
Income.
is cell mediated. The cells are causing the problem, not the antibodies and antigens. Okay.
Yes.
So I think you have got this one also. Alphas we have discussed. Okay.
Yes, sir.
Basket weave is important. Splitting of GBM is important. It is one more important thing about alpha, it is hereditary, right?
Yes. X-linked dominant.
Yeah, X-linked dominant. So what they will give you is eye problems. We have the formula of can't see,
And we can't hear.
can't be, and can't what?
Here, here a B, like
Yeah, here a B. So we have these three problems also. Membranoproliferative. I have told you membrane will be thickened, basement membrane will be thickened. Proliferative, we will have hypercellularity. Okay,
yes.
so just from the name, you will understand most of the high yield points, okay? And it is because of the infections.
Hep B, Hep C.
The tram track appearance is important because we have the immune complexes forming where subendothelially they are like this. Okay, it is like tram track. Okay, so these points you should remember, and we will go through MCQs and it will be very helpful. Okay. Yeah, so we have done with question 6. What was it?
Deposition of amorphous material.
Yeah, so we had rheumatoid arthritis causing nephrotic syndrome, right? So it is amyloid deposition. Yeah.
Which of the following mechanism is most likely cause of the patient's abnormal findings? A 7-year-old boy is brought to the office by his mother due to facial puffiness that is especially noticeable in the morning. History of mild intermittent asthma that is well controlled by albuterol. Temperature is 36.1. Blood pressure is 98/62. Pulse is 89. Regular. Physical examination show bilateral lower extremity putting edema. Nephrotic range proteinuria consisting mainly of albumin is revealed on urine analysis. Which of the following mechanism is most likely cause this patient's abnormal finding? That's actually the minimal change disease.
Yeah, so the age is very important because is they have given nephrotic. Yeah. So we have nephrotic range, right? So we
Yes.
will from the first thing you guys to look into what is the condition, okay? Is it nephritic or nephrotic, okay? This is the first thing. So you will exclude most of the options, okay? You know, there's the five, six we have discussed now was of nephritic, right?
Yeah, yes, and nephrotic.
Yeah, so you will exclude all these when you just look into the range of the proteinuria, okay? The other important point over here is in nephrotic, the most common cause of nephrotic syndrome in children
Name changes.
is minimal change, okay? If we
Okay,
have 100 children of nephrotic syndrome, almost 90 will be because of minimal change, okay? Got this?
okay,
So the age is very important here, okay?
okay, sir.
Why it is called minimal change? Because we don't have anything on immunofluorescence.
We have
Mm,
glomeruli in the microscopy.
yeah, light microscopy, we only see on
Elect
electron microscope that photocytes
are fused, effaced.
are effaced, okay? And the effacement is because of
Cytokines.
swelling. Swelling caused by
Cytokines.
cytokines. And we have cytokines, not antibodies, right?
Yes.
So we won't have anything on immunofluorescence, okay?
Okay,
And we have given the important cause of lymphoma. So lymphomas are producing a lot of cytokines, okay?
yeah,
So what we discussed that the most common cause of nephrotic syndrome in children is minimal change, right?
yes, sir.
The other important point is it is caused by cytokines. So
Yeah,
how will you remember the cytokines part? From lymphoma, okay, that lymphomas are producing lots of cytokines, and you can also see that we don't have anything on immunofluorescence. We have normal glomeruli, so we don't have any antibodies or immune complexes, okay?
okay,
So somehow you have to remember these things, okay? But other important things are in minimal change is we have your book have given for anyone who wants to
That's idiopathic infection, immunization, and
radio infections and bee sting. You will have somehow given bee sting, idiopathic infections,
immunization status. Actually, post immunization.
yeah, immune stimulus. This is immune stimulus and immunization, okay? So these are the important points of nephrotic syndrome, okay? So we have, what do we have? Asthma. Asthma, right? So what is it? Asthma is causing nephrotic syndrome.
nephrotic.
It is an immune stimulus, okay?
Yeah,
Yeah, so what's the question asking? Which of the following mechanism is most likely the patient abnormal laboratory findings? So what's the option? What will happen when the podocytes are effaced?
and the
Podocytes
proteins
are
will leak.
albumin
Proteins
Protein really.
will leak.
leaked. Okay, so we have increased filtration of plasma proteins. Okay,
Proteins, yeah.
Yeah, and what about the other option? Just quickly go through it. Impaired tubular reabsorption of filtered protein, so it's not relevant that the filtration is. Tubular things are not relevant in nephrotic syndrome, right?
Uh,
What about inflammations of urinary tract? So UTIs does not cause nephrotic range proteinuria, okay?
yeah.
Necrosis of skeletal muscle,
Mm,
myoglobin will be there, right?
yes. And it will be
Overproduction of
nephritic. Would be
overproduction
cause
of,
nephritic.
sorry?
It will cause nephritic syndrome if that is the case. Like,
Yeah, yeah,
okay,
it is most in the nephritic picture, okay?
okay.
And what is the overproduction of low molecular weight proteins?
Multiple myeloma.
Yeah,
Multiple myeloma.
yeah, great.
Low molecular weight proteins.
Yeah, so now we have some basic knowledge. We will go quickly through the questions, okay?
Okay, sir.
Yeah, anyone please?
Seven.
Urine analysis. Oh,
Okay, fine.
okay, go ahead.
A 17-year-old boy is brought to the office due to occasional blood in the urine. The first episode occurred 1 year ago during a flu like illness and resolved spontaneously. The patient had a similar episode about 6 months ago, which seemed to resolve. He has no other medical condition and does not use tobacco or alcohol, no history of blood or kidney disorders in the family. Vital sign normal. Laboratory elevation is the blood urea nitrogen level is 14 and creatinine is 0.8. Urine analysis is given. Specific gravity is 1.013. Protein is class 2.
Yeah, okay. So just from the stem, you can get most of the
Yes.
question, okay? So we have 17-year-old boy on occasional blood in the
Blood.
urine, okay?
Yeah,
First,
So from the when you see color change of urine, like cola colored urine, or if any thing they have given you like blood, so you can simply exclude the nephrotic, okay?
okay,
So
sir.
in nephritic, we have
Nephritic.
hematuria, right?
yes,
We
and
Yes,
even
don't
the
have,
protein suggests plus 2. It's not erotic range.
yeah. So you can also see from here, but I am just saying the basic concept is we have hematuria, right, in nephritic.
yeah,
We don't have hematuria and nephrotic. What other
nephritic.
things are renal failure? Okay.
Yeah,
So in such conditions, the CRET and BUN
creatinine
will
is elevated
always
and
be
urine
elevated.
high.
Okay. And
Mm-hmm.
nephritic. Also, we will have blood pressure. Okay. And edema.
Yeah.
Okay.
Yes, sir.
Okay, sir.
So these are specific to nephritic, while in nephrotic, the important thing is proteins and lipids, okay?
Lipids.
Hyperlipidemia more than 300. Why is it this picture? Because liver tries to
Compensate for the protein.
compensate, okay? So liver is producing more and still it is unable to compensate, okay? Guys, I have a, question
Mm-hmm.
that what do you think, nephritic is more severe or nephritic is more severe? Nephrotic or nephritic?
Nephrotic?
Nephrotic.
Nephritic.
Anyone else?
I think nephritic because it's bleeding, something like that.
Yeah, that's the important point, okay? So all the conditions, most of the conditions that are causing nephrotic can, after some time,
Cause
goes to nephritic.
Nephritic.
So
Oh,
you don't have to look into the proteins because the less protein in nephritic is because of decreased GFR, okay?
yeah.
And the decreased GFR is responsible for decreased outflow of proteins. And why GFR is decreased?
Because the kidney function is deteriorating and it may lead to end-stage renal disease very soon.
Yeah, so what's the cause of decreased GFR? Why is GFR decreased? Because
Because the filter is not
in
working.
nephrotic, in nephrotic we have normal endothelium somehow normal, okay? Like, and same for the basement. The main problem is in the podocytes, right?
Right.
Yes.
And over here we have the glomeruli injury, okay? So normally the picture will be the picture of the kidney diseases will be first from mild to, I'm going from mild to severe, okay?
Yeah.
We will have selective
Protein studies.
proteinuria, which will be albumin, okay?
Yeah.
Then we will have non-selective. The light chain proteins will be also getting removed, okay? Then we will have nephrotic, okay? Then nephritic. So in nephritic we have hematuria, okay? Then it will goes to acute renal failure and chronic. This is how the picture is, okay?
So can we
So
go with one more time, please? The picture.
I was saying that if we have a mild injury, okay,
Yeah.
the
Okay.
podocytes are very, very sensitive, okay?
Okay.
A slight effect on the glomeruli will swell the podocytes, okay?
Okay.
And we will have selective proteinuria, okay? So if this is
Okay.
a podocyte, so we have some proteins over here that is attaching to the basement membrane, okay? So a
Okay.
slight insult to this will swell this up, and we will have albuminuria, okay?
Okay.
If the injury is slightly more, we will have non-selective. We will have albumin plus light chain proteins going out in urine, okay?
Okay.
If the injury is more severe, we will have more than 3.5 grams of protein leaking. If this is even more, the protein will be less than 3.5, but we
Okay.
have hematuria, okay?
Hematuria.
And then
Okay.
we are going to renal failure, okay?
Failure. Okay. Thank you, sir.
Similarly, similarly, what we have is like minimal change, right? The first one, guys,
Yes.
do memorize these
Minimal
things
change.
in order so you
Okay.
will not forget it, okay? So
Okay.
similarly, minimal change, it is the injury is like we can say
Mild, so
a plus,
albumin.
okay? We can label as it is a plus, okay?
Okay.
So after that, you have given in your book is focal segmental glomerulosclerosis, okay? So we have discussed the nephritic, now we will discuss some of the nephrotic, okay?
Okay.
So in FSGS, we also have the picture of minimal change. You know this, right? But along this, we have hyalinosis, right? Hyaline deposition, right? We call it hyalinosis or sclerosis, right?
Okay.
So the injury, I can label it is double plus, okay?
Okay.
So I'm just making a concept for you so that you can understand how is the pathology going on, okay? So the second is more severe than the first one, okay? So here we have only podocytes effacement, right?
Yes,
Minimal
sir.
change. Here we have podocytes effacement plus hyalinosis, okay? So
Oh,
this is the disease is going more aggressive, okay, becoming
aggressive.
or we
Severe.
can say
Oh,
the injury is getting a little bit more and more severe, okay.
severe. Okay.
But if I ask you about it is focal, right?
Yeah.
So if it is, what is the opposite of focal? Diffuse, right?
Yes.
So diffuse will be more severe than focal, okay?
Okay. Mm-hmm.
Got this?
Yes, sir.
So
Yes.
this is how the disease is. The disease, we can say injuries, okay? And we have membranous, okay? So we only have basement membrane thickening, right?
Yes, sir.
But if we have membranoproliferative glomerulonephritis, so it is more severe than this, right? So
Yes,
we will
sir.
have membrane thickening along with
Cell
cellularity,
proliferation.
increase cellularity. Getting
Oh,
this?
yes, yes, sir. Yeah, now we're finally getting it. Yeah.
And what about rapidly progressive glomerulonephritis? This is the most severe. It is causing
Yes, sir.
nephritic, right?
Yeah.
So it is, we can say from the nephritic range, it is like more severe and the more severe than FSGS and others, okay? Membranous, okay?
So it has both nephrotic and nephritic, both symptoms.
Sorry? No,
So
the
it,
symptoms. So we have hematuria also in here, right?
yeah,
So the rapidly progressive is more severe than the others, okay? But over here we have crescents.
yeah.
The crescents is leading to rapidly progression to end stage renal disease, okay? So
Okay,
in a picture, if now after that, if you see a biopsy, you will understand that what are they saying, okay? You will get in the questions, okay? All these discussions will be very helpful for you guys, okay?
okay, sir.
Yeah, so where are we? So he had, anyone please help me out. I am lost in the question.
Yeah,
Okay.
Oh no, no,
which
don't worry,
everyone
sir.
Yeah,
it was
so
Urinalysis. We were going through
yeah,
the
so
urine.
he is a 17-year-old and he had nephritic range of proteinuria, okay?
Yeah,
And the other important thing in the IgA nephropathy is the symptoms, the hematuria will be episodic, okay? This
mm.
is the most high yield point, okay? We have discussed the time, right? Days
One,
after, okay?
uh,
Sorry?
1 to 2 days, you told us, right? Some days history.
Yeah, so the other was time, right? The days
Yeah,
and weeks, right?
yeah.
But the most important in the stem, you will have the episodic nature of
Yeah.
hematuria, okay? So
Oh,
this is the episode of the first episode occurs 1 year ago during a flu-like illness and resolves spontaneously and had similar episodes 6 months. So if you see the infection or the sorry, the hematuria is episodic, so it is very high yield and going to
I
IgA
yeah.
nephropathy. Okay, he has
okay.
no other medical conditions. There is no history of kidney disease in the family. Vital signs are normal, and I have told you in nephritic what you will see the BUN levels. Here they are normal, but you can see it will be increase in case of renal failure. Okay, got this? If
Yes.
the nephritic
Yes.
is going more aggressive, it will cause renal failure. Okay, so what's the question asking? So, anyone, how much of the questions have you got? How much of the questions? So, we have red blood cells in cast. Okay,
Yeah.
hematuria,
Mhm.
proteinuria,
I'm red blood cast.
and what else we have? Sorry, I discussed
Mm,
other things, so I forgot the question what I was
mm,
discussing.
So you
Yeah,
almost asked all the question we were just about to end you because all
yeah.
other negative, right?
So
Yeah,
what do
we were
you?
the
Sorry.
options.
Yeah.
I
So
know the following.
Have pharyngeal deposition of IgA like this.
IgA nephropathy.
yeah. So
Mm,
let's discuss some of these. What is
yeah.
this?
F. Mesangial deposition of IgA.
Am I right?
Apple green birefringence. What do you understand by birefringence?
It's actually
That's in amyloidosis, right?
my
We see
Yeah,
that.
so we have the amylite
protein.
present somehow like this,
Okay,
okay?
okay,
So if we look it into the under the polarized light, so some of the radioactive substance will be taken like this, okay? And this portion does not have took the
Thing.
we can say the ink, okay? But
okay,
if we look from this side, so this part will have taken it and this would not, okay? So it will be giving us the by means true, okay? So it will be some areas will be enlightened and some will be not, okay? And
okay,
it is the pathognomonic for amyloidosis, okay?
okay.
Yeah, okay. Crescents,
In rapidly progressive
Rapid progressive.
glomerulonephritis.
effacement,
Minimal change.
Minimal change.
granular,
PSGN.
ESGN.
okay, and lamellated.
That means linear.
Good pastures? I don't know. Laminated. Never heard of that. It's like thickening of basement
What does
We
membrane?
have we have
laminated means?
lamellated or we have discussed weakened alpha,
Palsy. That, yeah.
mesangial
Uh,
alpha,
Okay, okay. So when
uh,
Berger.
they want to say, okay, okay. When they said basket weave and this, they will say laminated. Okay.
Okay, sclerosis of the portion. Okay, so the portion is segmental. Okay,
Segmental,
focal,
yeah.
segmental
Yeah,
glomerulonephritis.
mental, yeah.
And this is not of that much
yes,
importance.
it's a
Forget about it.
distraction.
Okay.
Yeah.
Okay.
So this lamellated, sir, is the same as the basket weave thing?
Yeah.
Is it? Oh,
Mm.
it's another word for it. Okay.
Yeah. So
So how did you draw it? Like, I want to visualize it. Like, how is this lamellated basement
yeah,
membrane?
I don't know.
If
I will
you
look
have
it.
any
Uh,
pictures, like,
I
um,
will look at it for you. Okay.
okay, so thank you.
Okay. So you got your answer right. IgA. Okay.
Yes, the IgA.
You can exclude. You can do it on exclusion basis. Okay. Like we don't have any infection. Yeah. We don't have a recent infection like in weeks. Okay. We don't have proteinuria and nephrotic range. Okay.
Okay.
We don't have rapidly progression. Okay.
Mm,
We don't have amyloidosis, something going on. Okay.
okay.
We don't have any ulcers like the triad. Okay.
Mm,
And yeah, so this is how you will do your questions. Yeah, anyone please?
The old
Which of the following glomerular changes are most likely to be present within this patient's kidney? 5-year-old girl is brought to the clinic due to 2 days of dark red urine. The patient was treated for facial impetigo a month ago. Blood pressure is 140 over 90. Urinalysis reveals hematuria, mild proteinuria, and occasional red blood cell cast. Which of the following glomerular changes are most likely to be present within this patient's kidney?
Yeah, so it's easy, right? And Pitigo.
Yeah,
yeah,
Streptococcal glomerulonephritis.
PSGN.
And we have sub
subepithelial.
Yeah,
subepithelial
pumps.
humps on.
Subepithelial.
Yeah,
Oh my gosh.
yes.
So now you can do the questions very easily, okay?
Yeah, thank you, Dr. Hisham. You make
Mm,
things very easy. Actually, this was
Thank
very
you.
hard for
Thank
me.
you so much.
Thank
Thank you
you
so
very much.
thank
much.
you, Zafir. Yeah, thank you for explaining it so well. All this time we were like memorizing, but you kind of showed
Yeah,
us the sequence of like how things get worse.
thank you.
every disease. Thank you.
Yeah, so anyone please?
Um, which of the which of the following is most likely responsible for this patient's current condition?
Okay.
81-year-old woman reports progressively increasing bilateral shoulder pain for 2 months. Over the past 2 weeks, she has developed burning pain in her right thumb, index, and middle fingers. Medical history is significant for type 2 diabetes mellitus and end-stage renal disease due to diabetic nephropathy. Patient has received hemodialysis for the past 10 years. Vital signs are normal. Examination reveals normal heart and lung sounds. There is no organomegaly. Both shoulders are hypertrophied. There is thinner atrophy on the right hand and soft tissue fullness at the right wrist. Which of the following is most likely responsible for the patient's current condition?
Yeah, so what do we have?
This is diabetic nephrosclerosis. Uh,
Yeah, so we have 81-year-old
old
bilateral shoulder pain.
shoulder pain.
Sorry. So we have some musculoskeletal sign and symptoms, maybe due to age,
Age.
burning pain in right thumb. So we will discuss that in MSK, okay? Don't confuse
Yeah.
yourself on extra things, okay? Type 2
Uh,
diabetes and end stage renal
End-stage renal disease.
disease, okay? Due to
Yeah.
diabetic nephropathy. He has
Nephropathy.
been on hemodialysis. So
Uh,
he has been on hemodialysis, examination reveals normal heart, no organomegaly, shoulders are hypertrophied, thenar is atrophy. Which of the following is responsible for the current condition? So if you don't get the exact answer just from the stem, so look into the options so you will understand what are they asking, okay?
okay.
Sometimes the options are also helpful to understand the question completely, okay? Sorry. So they are talking about transthyretin, right?
Yeah.
Microglobulin, amyloid A proteins, and light chain. Yeah. So, what do you
I
understand from
will.
this? We are talking about amyloid
My
deposition. Okay.
yeah,
So, what is the cause of amyloid deposition in stage
hemodialysis. Yeah,
renal
Renal
disease and
disease.
hemodialysis? And what happens there? We have deposition of
position beta to
beta two
microglobulin.
microglobulin.
Macroglobulin. Yeah,
Microglobulin.
also I
Don't
think
don't
carbon.
worry, don't worry if you did not get the amyloidosis questions correctly because you do not have studied amyloidosis in great details. Okay, you just have
Mm.
to understand what is causing it in kidney. Okay, we have discussed this. Now you can see it again.
Yeah, we have to see that.
So multiple myeloma,
Mm.
light change. Okay, chronic
Hello.
inflammation and infections, TB, etc. Serum amyloid A, elderly man, transthyretin. Okay, and most importantly, in ES, end stage renal disease on dialysis, beta 2, microglobulin. Okay, got this?
Yeah. But
So,
this
doctor,
can
I do have a
also.
question.
Yeah.
I'm sorry, I do have a question. Like when we are
Okay.
talking about the 81-year-old women, so how do you find that sex differentiation in
Yeah.
each and every question? Like, when you're looking at it, like when you say
Sorry.
18-year-old women,
Yeah.
few of the diseases are very universal, right? Few diseases are more in male and few diseases are more in female. So how do
Mm.
you not consider those points is my question. Or how would you know that you have to consider if
Yeah.
I have to consider sex or not?
Yeah. So, like yesterday, we were discussing posterior urethral valves, right? You remember that point?
I'm not there. This is my first class.
Yeah. So, some conditions are just specific to that gender, right? Like X-linked dominant, we will have more in boys. Okay, posterior urethral valve, it is occurring in the posterior urethra, right? The membrane is just only in boys. So in some conditions you have to remember these points, that is occurring in males more, or some of them are occurring in females. Okay, like if you look into this specifically this stem, so if it is an 81-year-old woman or it is an 81-year-old man on end stage renal disease, it will be, there is the effects will be same. Okay, so it
Yeah.
doesn't count here. Okay, so in some conditions, like we will be discussing on our coming questions, some conditions will be specific to gender. Okay, like
Yes.
Dr. Imran have studied with you COPD. Okay, so COPD, the smoking is the main concern, right? So you know that males are more smokers compared to females. So this is how you will understand some of the disease will be related to specific diseases. Okay,
Okay.
Okay.
so you don't have to go into each and every point in question, that why it is like this and why it is not. It will confuse you. Okay, you have to pick the high yield points in your question. Okay, so we will left this question. It is about the immunological response. We will discuss it in immunology, or I will discuss it in some other class. Okay.
So
Yeah.
another question I have is
Yeah,
like,
please.
so when they mentioned that the patient is a diabetic patient,
Yeah.
what
So,
came to my mind was like focal segmental glomerulosclerosis, but then it turned out to be like they're asking
yeah.
about amyloidosis.
Yeah,
So
that's
like,
why, and that's
uh
why when I read it first, same problem over here. So you have, when sometimes you don't get the question completely, you have to look into the options. And the other thing they have mentioned, that because of the type 2 diabetes and
yeah.
because of the diabetic nephropathy,
Hmm.
he is in end stage renal disease, and he is on hemodialysis, right? So
Oh,
they were going through a disease that is leading to hemodialysis and end stage renal disease, which is causing amyloid protein deposition. Okay.
okay, okay. Oh wow. Okay. Thank you, sir.
No problem. Yeah, anyone, please? Yeah, so I will skip this. I have skipped two questions for you guys. Okay. Yeah, anyone, please? Anyone? Guys, anyone? Why is everyone silent?
Me, I'm checking my dinner.
I think you guys are bored. So we should end this, and you have 20, 30 questions to do it yourself, okay? Yeah, anyone,
Okay,
please.
good. I can do it.
Go.
Palpable purpura and pitting edema are present in bilateral lower extremities. Laboratory results are as follows. A 42-year-old man comes to the office due to a 2-week history of reddish brown urine, fatigue, joint pain, and a lower extremity rash. The patient has no medical history and family history is unremarkable. He has had multiple sexual partners and only uses protection intermittently. Temperature is 37.7 Celsius, blood pressure is 146/94, and pulse is 75. Palpable purpura and pitting edema are present in bilateral lower extremities. Lab
So
results
crit
are as
is high,
follows.
crit
Creatinine
is
is
high,
high,
C3, C4 is low, he has
low,
uh,
is low,
proteins is high,
protein is
and
low,
we have several RBC cast,
several
okay?
casts, yeah. Immunologic mechanisms. Which of the following immunologic mechanisms is most likely responsible for this patient's renal injury?
Yeah, so it is a separate topic. If you guys know that, what are the substances that is, what are the processes that is responsible, and what are the mechanism that is responsible for the glomerular injury? Okay, what are they asking about is mechanisms. Okay, immunological
Hmm.
mechanism, right?
Yeah.
So I think we will discuss it
Yeah.
after some questions. It will
Yeah. If
take a
it's
lot of time.
different, we'll uh, group it with whatever is similar to it, right? Like,
Yeah, okay. So this one, please.
okay. Um, which of the following additional findings is most likely to be present in this patient? A 42-year-old man comes to the office due to hematuria, fatigue, and nasal congestion for the last few weeks. He has no chronic medical conditions. Blood pressure is 160/96. Physical examination shows edema around the ankles, hands, and face. Laboratory results reveal blood urea nitrogen of 40, serum creatinine of 3.8. Urine analysis shows moderate proteinuria and a large amount of red blood cells with RBC CAS. Kidney biopsy is performed. Light microscopy reveals cellular proliferation, focal necrosis, and crescent formation of most of the glomeruli. On immunofluorescent microscopy, there are no immunoglobulins or complement deposits. Which of the following additional findings is most likely to be present in this patient?
Yeah, so we have cellular proliferation on biopsy. So
Yeah.
we just jump to the high yield points. Okay, the
Okay.
biopsy is very important in such questions. So we have focal necrosis,
Hmm.
crescent formation.
Yeah.
RPG,
Okay,
So it's
there is no
sorry,
immunoglobulin
immune,
or complement deposition.
deposits.
Yeah, so I think you got your answer very easily. What is
So
the
there's
condition?
RPGN, right? Rapidly progressive
Yes.
glomerulonephritis.
Yeah,
So
so
now,
we have to look into. So they are asking about which of the following additional bonding is most likely to be present in. Yeah. So what's the what are the diseases that is leading to RPGN? Linear,
Patrick,
linear eye
renal,
immunofluorescence. What? Which was?
good pastures, we have
good pasture.
Yeah. What's the second one?
passing,
Yeah. So negative
Pasture.
or passive immune. What is this? What is the cause of
Vas-
this? Vasculitis. Okay. So we have ANCA, right? Anti-nuclear, sorry, anti-neutrophilic antibodies, right? Cytoplasmic antibodies. And what's the third one? Granular, okay? So granular, post-streptococcal, right?
Yeah.
What other, right? Diffuse, proliferative, glomerulonephritis. So all these can lead to our PGN, okay?
Okay.
So first you have, now come to the question. First you have diagnosed, we have RPGN,
RPGN.
okay? Just from
Okay.
crescents formation, you can
Only.
get this,
Yeah.
okay?
Yeah.
Now, what are the, what do we have in our options that we have decreased C3 levels? So C3 levels can be decreased in
yeah,
post-streptococcal, right?
Yeah.
So the C4 is not specific but can be decreased in PSGN, okay?
yeah,
Okay.
And DPGN, we have, I think, full house in this, right?
yes,
Yeah. So this one can be correct. This one can be correct. The third one, serum anti-glomerular basement membrane
Batman.
antibodies. So
yes,
antibodies again against basement membranes are
good
Good
past,
Good pa-
pasture.
Sorry?
Good
Good
pasture
passion.
syndrome.
Yeah, so we have good pasture, okay?
Okay.
And give me a second. Yeah, so it can be good pasture. And what about D? Neutrophilic,
Okay.
so
That's
vasculitis,
it.
okay?
Yeah.
So all can be true, right?
Mm.
So let's come over again to the stem on immunofluorescence. There is no immunoglobulins or complements deposition.
So that means good pastures is
So really,
out.
So the
past
only one remaining is
S
past
OC
life.
and K.
immune.
Mm.
Uh,
Yeah, so
mm.
got this?
Yes, sir. Yeah. Got it.
Two.
Usually they say C and K is positive, but in this case they didn't give that.
Yeah.
So
So
we
what's
get to
this
eliminate.
picture?
Crescents.
Yeah,
Uh,
great. So
crescent.
this is what crescents look like.
Crescent.
Okay.
Person.
Oh, wow.
So anyone who wants to read?
34-year-old man is being evaluated for acute hematuria and oliguria. He has no chronic medical conditions and takes no medications on regular basis. BP 170 over 100, BUN 38, serum creatinine 4.5. The patient undergoes kidney biopsy, and the following microscopic changes are seen after silver staining to highlight the glomerular tuft. Mm,
Okay.
yeah.
So
Um, the area marked with the arrow is likely to have abnormal deposition of which of the following substances?
so it is crescent FSGS. Okay. So we have
Five.
Fibrin.
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 Okay.
Fibrin. Yeah.
Fibrin. Yeah.
Now the questions are becoming easy for you guys.
Yeah.
Yeah. Anyone, please?
Go. Microorganism most likely responsible for this patient's condition is also commonly associated with which of the following conditions? A 35-year-old man is admitted to the hospital after he fell off a moving tractor and caught his right leg underneath the vehicle. The patient has no past medical history. Over the next few hours, he develops worsening severe pain and rapidly increasing swelling in the injured right leg. Crepitus is present on physical examination. Emergent radiographic imaging reveals gas in the tissues. Surgical evaluation is performed, and the microorganism most likely responsible for this patient's condition is also commonly associated with which of the following conditions?
So it is somehow out of
Cross.
the out of the what we can say. So
Mhm.
we have a different questions. We have a different
Yeah.
question now. So
Mm-hmm.
we have
Yeah.
a person fell off from tractor and caught his leg
Yeah.
underneath the vehicle. No past medical history. He develops worsening pain, rapidly increasing swelling, injured right leg. So we have crepitus, okay, and we have gaze. Gaze. Okay,
Yes.
surgical evaluation is involved in microorganism. So what do you think they are talking about?
Clostridium.
Yeah, Clostridium perfringens.
Perfringens.
And and where do you see these type of cases? Which ward? You will come along such cases in hospital if the patient after injury got gas gangrene, right? In plastic surgery ward, right? We see lots of cases, right, like this. Yeah, so we have Clostridium perfringens, and the second important problem with Clostridium perfringens is watery
Diarrhea.
diarrhea. Okay, so Dr. Ali will take the class also on Clostridium perfringens. Don't worry, okay? So he will discuss it in great detail. Okay. So the high yield points are gas gangrene, okay, and watery diarrhea. Okay, got this?
Yes, sir.
Yes, doctor.
Now we have next question. Yeah, what is this?
This is red-green birefringence.
Yeah, great. So what's the condition?
It's amyloidosis.
Yeah, so should we read the question or just we
Mm,
jump to
we
the
can
option?
try with jumping.
You can jump to the other question.
Yeah, so it's easy. So I will read it for you. A 55-year-old man is evolved due to worsening fatigue and dyspnea. He has no chronic conditions and no medications. He has taking no medications. Physical examination shows facial puffiness, which is edema. Bilateral lower extremity edema also. The proteins are in nephrotic range, right?
Yes,
Amyloidosis
sir.
causes nephrotic conditions, right? And under
Yeah.
polarized light, we see apple green by refringence. Oh, and what's the stain? Congo red
Red.
stain.
Red.
Okay. So what we will do? Is it concerned with uric acid, copper, bilirubin, or iron?
No,
No.
for
So we
protein
have
basis.
proteins.
Protein electrophoresis.
Yeah. 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 Anyone, please.
A 41-year-old woman is being evaluated for peripheral edema. The patient has gained 6.8 kgs over the past 8 weeks. Her urine is frothy. She has no other medical problems and takes no medications. The patient does not use tobacco, alcohol, or illicit drugs. Blood pressure is 140 over 90 and pulse is 80. Examination shows generalized edema. Heart sounds are normal. The abdomen is soft and non-tender. Serum creatinine is 1.1 milligram per deciliter. Urine analysis shows 4 plus protein, 0 to 3 leukocytes per hyperfilled and oval fat bodies. Serum contains IgG4 antibodies to the phospholipase A2 receptor, a transmembrane protein abundant on podocytes. Which of the following is the most likely diagnosis?
So we have given nephrotic range, proteinuria, okay?
Yeah.
Yes, sir.
So in such cases, you will have in mind diseases like first minimal change, then focal segmental, okay? Then then membranous, then amyloid, then diabetic, then MPGN, okay? So
Okay.
you will have in mind these conditions, okay? So after that, you will see that what is this receptor or where we have seen this receptor, okay? So what do you think?
Membranous nephropathy.
Membrane, because it's a
Yeah,
basement
so
membrane.
we have this protein present, or is it present, or what we can say, is it present or basement membrane or podocytes?
Base. What is it?
I think the receptor
Transmembrane.
is on, I forget, I
Heart.
will look at
I forgot.
so
Um,
so we have, yeah, what's your answer?
So it says transmembrane protein abundant on podocytes, right, sir?
Yeah, I think it's present on podocyte.
Podocytes.
Okay, right.
Podocytes.
Yeah, so we have,
So,
I have told you we have minimal change disease, okay, and we have focal segmental and we have membranous, right? So if they have just given you the receptor, so you will straight go forward for membranous, right?
yeah.
So this is kind of pathognomonic for the condition. Okay. So what other important things are in membranous is NSAIDs, penicillamine.
Penicillin.
What is penicillamine?
Penicillin.
Uh,
Penicillin. Chile,
Copper
As a
chelating,
corporate
okay.
relation.
Agent, okay. So yeah, we have just seen our question. I don't think we can discuss it more because in minimal change we won't have this receptor, okay. What else we can see in this question? Yeah, I think the rest of the stem does not show any differences, okay.
Yeah.
Yeah, they have written it.
How
Sorry.
about frothy urine? Like,
Yeah,
are there
so
any drugs causing frothy urine too, right?
yeah, so frothy urine. Why
It's
it's
because
frothy? Why we have
Protein,
Profit,
oval bodies?
more protein.
nephrotic oval because of the lipids.
Yeah.
fat,
Yeah, we have
Fat.
lipids, okay. So and oval bodies when lipids are wrapped in membrane, okay. So we call it oval bodies, and we have more than 300. Uh, what's the unit? But we have more than 300 lipids, okay, in nephrotic syndrome. Yeah, so I am getting very slow. So what we learned in sorry, membranous, the receptor is important. Okay. The other important point over here is minimal changes causing what? Nephrotic syndrome, right? We will
Yeah.
have the phospholipase receptor given, okay, and we have the penicillamine, okay,
Yeah. Mhm.
and other conditions like SAD, etc. Okay. Yeah, anyone, please?
screening of early stage diabetic nephropathy in this patient would best be accomplished by measuring the urinary concentration of which of the following substances. A 21-year-old woman with type 1 diabetes mellitus come to the office for follow-up of an appointment. She has been using daily long-acting and short-acting insulin injections from the time she was diagnosed 6 years ago. The patient was seen by her ophthalmologist when had signs of diabetes. She takes a balanced diet and jogs every morning for 40 minutes. On examination, the skin of her extremities is intact and peripheral pulses are palpable. Sensory examinations show normal pinprick vibration and temperature. Sensation in her lower extremities. Laboratory evaluations show normal renal function tests and lipid profile. The patient HbA1c is 7%. Screening which of the following would be accomplished by measuring the urinary concentration of which of the following substances.
So, what are they asking about? The
Right,
screening of
definite, early
early stage diabetic nephropathy and would be accomplished by measuring which concentration?
albumin.
Yeah,
So albumin,
so this is the
creatinine.
diagnostic. This is the diagnostic for early stage diabetic nephropathy. Okay, they have given that where is it on us? Let me see. Yeah, no signs of diabetic retinopathy on ocular examination, right? So are asking about early stage, okay? Early stage will be seen through albumin, okay? The glucose will tell us about the diabetes, okay? But it does not tell us about diabetic nephropathy, okay?
Okay.
Same for the ketones. We have ketones in ketonouria and diabetic ketoacidosis, RBC cast in hematuria, RBC cast. We have these in nephritic syndromes, okay? Vexi cast and end stage renal disease, right? So the point over here is they just want to know that whether you know or not that albumin is used to used for the screening of early stage diabetic nephropathy. Okay. Yeah. Yes, please.
a 7-year-old boy
Yeah, go on.
A 7-year-old boy is brought to the office due to swelling of hands and feet. 2 weeks ago, the patient was treated for anaphylaxis following a bee sting. During the past 10 days, he has had progressive hand and foot swelling, and his pants feel tighter than usual. The patient's urine has also become frothy. Examination shows periorbital edema and pitting edema of the hands and feet, as well as mild ascites. Lungs are clear to auscultation. Urine analysis results as follows: protein 4 plus, blood glucose ketones are negative, casts are highly cast, white blood cells, red blood cells are insignificant.
So we have a young child, 7-year-old, right? We
Yeah.
have a 7-year-old boy with
Yeah.
a nephrotic
Syndrome.
range of proteinuria, and he has bee sting, right?
That's
Yeah.
actually infection from a bee sting.
Yeah, so what were the four eyes? We have discussed infection,
No,
okay? One of it was. So
Infection.
what is it? Minimal
Change disease.
change disease. What do we have on minimal change? Only effacement, okay? On electron microscope,
microscope.
okay? The rest will be normal. Let's look into the options. Light microscopy will be normal, right?
Yeah.
Light microscopy,
Normal.
normal, okay? The rest are cellular proliferation, crescent, diffuse thickening.
E.
We have discussed most of them
E.
already. Negative for
E.
complements, it is okay, and effacement is.
Assessment is E. Yeah.
Okay.
Mm.
Doctor, regarding the Highline cast, so we will not look at this one.
Sorry?
Yeah, I'm with you. This is a minimal change. But what about the Highline cast?
So
Yeah,
where do we
is
see
it
the hyaline cast?
Island cars are actually seen in normal conditions, I think, most.
Yeah, in dehydration exercise, right?
okay?
So about casts, you can see in your book. I think I have it.
There's a table actually. We have to memorize it.
Yeah, so we have RBC cast in glomerulonephritis, okay?
Yeah.
WBC cast, tubulointerstitial, okay? You don't have to memorize all at once. You will get it once you go through all the disease, okay? Granular cast is important. Most of the time they ask about it in ATN, okay? Fatty cast, you know the concept, so you don't have to memorize it, okay? Vexicast, we have discussed it in stage renal disease and hyaline at dehydration, okay?
Okay, thank you, doctor.
Yeah. So is it that I'm getting very much tired, or you guys also got tired?
Well, we
I
also
don't know.
tired.
I became very much tired. Maybe my day was a bit hard. Okay, anyone please?
Yes.
Okay, a 10-year-old boy is brought to the office due to dark brown urine that he first noticed yesterday after swimming practice. Blood pressure is 130 over 80. Physical examination is normal, with the exception of bilateral periorbital edema. Labs showed normal sodium, potassium is normal, BUN normal, creatinine 1.4, creatinine kinase 86. I'm not sure about the normal. Protein 1
Okay,
plus. Yeah, if you can go down a little bit, doctor. So he having RBCs cast.
okay.
Yeah.
So which of the following is
Mm.
most likely diagnosis? Is it minimal change?
No.
No, because it's a nephritic, not minimal change.
Yeah. What
No.
about nephrolithiasis?
No.
No, no,
No.
What about
change.
pyelonephritis?
No.
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 We don't have fever, nephrolithiasis, we don't have
Mm.
pain,
White
Yeah.
blood cell.
we don't have
Yeah.
proteinuria, so we are excluding minimal change.
Yeah.
What about rhabdomyolysis?
It could be
No.
because after
We will
swimming.
have we will have effect on muscles, right? After
Yeah.
strenuous
Yeah.
exercise,
Strenuous exercise.
we will
Yeah.
have elevated creatinine kinase also.
Kinases.
Okay,
Yeah.
Yeah.
so the only one we have is
Post.
Post-infectious
yeah. So these
pneumonia.
questions are getting easy, right?
Yeah,
Post.
finally. Yeah. Getting
Post infection.
Yeah, anyone please?
it. This patient most likely has which of the following conditions? A 24-year-old woman comes to the office for the evaluation of joint pain, fatigue, edema, and weight gain for the past 4 weeks. She has no previous medical conditions except for recurrent oral ulcers. Patient takes no medications and does not use tobacco, alcohol, or illicit drugs. Blood pressure is 130/80 and pulse is 80. Examination shows oral mucosal ulcers, facial puffiness, and 3 plus peripheral edema. Swelling, erythema, and tenderness are noted over the bilateral metacarpophalangeal and proximal interphalangeal joints. Cardiopulmonary examination reveals no abnormalities. 24-hour urine protein excretion is 4.5 grams. Serum antinuclear antibodies are present. Kidney biopsy shows glomerular capillary wall thickening with no increase in cellularity. When the sample is stained with methenamine silver, irregular spikes protruding from the glomerular basement membrane are seen. This patient most likely has which of the following conditions?
So what do we see on biopsy?
Biopsy we see irregular spikes,
Yikes.
mm,
Capillary wall thickening,
gradual thickening,
glomerular thickening
glomerular
with
thickening,
no increase in
increasing
cellularity.
cellularity.
Okay,
So
and
it's, yeah,
spike and dome appearance. Okay,
apparent membranous nephropathy.
Membranous.
so
F.
what is it?
Membranous.
Membranous.
Membranous nephropathy.
Membrane.
So the spikes protruding is, so we have two important pathognomonic signs. Okay, the
Hmm.
cellularity point we have explained. In
No increase
membranoproliferative, we will have increased cellularity
cellularity.
proliferative. Okay,
Okay.
and spikes appearance on methenamine silver stain shows spikes, which is the classic for membranous nephropathy.
Membranous glomerular.
Okay, anyone?
Which of the following is most likely pathogenesis of this patient renal findings? 23-year-old man come to the office due to 3 weeks of malaise and fatigue. He says, I've been sick with the flu for last 3 weeks. I don't know why I'm getting better. The patient
Sorry, sorry. Yeah, it was an infective endocarditis, so I think we should skip it. We will discuss it on some other sections. Okay. Yeah,
may I read this one then?
yeah.
To the
Sorry for the
most,
interruption.
sorry, it's okay. To the following is most likely explanation for the patient's laboratory. 15-year-old girl to the office for the patient was diagnosed with Wilson disease a year ago, at which time she began penicillamine therapy. Her
Okay.
dysarthritis performance have since improved. Her vital organs are normal. Laboratory results are shown. 24-hour copper is like 500 and now it's decreased. Urine analysis is normal. Yesterday 3 plus. 3 plus is like the nephrotic range of the uh,
Yeah.
have ALT and AST, they're actually decreased. Which of the following is most likely explanation for the patient's laboratory findings? So she's using penicillamine and she's having a nephrotic range, so that's membranous.
Yeah. So I think we have discussed the penicillamine, we have discussed the membranous enough, right?
Yeah, sir.
So NSAIDs, penicillamine, phospholipase A2 receptors,
Yes.
no hypercellularity, okay, SLE, etc.
Yes, sir.
They will all end.
Membrane.
nephrotic range, proteinuria.
Yeah.
So they will give you some of the hints and you will be easily getting the question. Okay.
Okay, sir.
Yeah, so they are saying pencil and educational objectives. Okay. The last point.
Mhm.
Penicillamine is a copper chelating agent used as a first line treatment in Wilson disease. Adverse effects include nephrotic syndrome, due, i.e., that is proteinuria, due to membranous nephropathy. Okay,
Okay, sir.
my internet is also tired like me. Yeah.
Which of the following patient characteristic is most likely to indicate poor long-term prognosis? Four children and two adults are currently being followed in nephrology clinic for PSGN. Three patients initially had gross hematuria and edema requiring diuretic administration. The remaining three patients had microscopic hematuria and hypertension. C3
Mhm.
levels were decreased in all patients and anti-streptolysin O titer was elevated in four of them. So
Mhm.
none of the patients had pre-existing renal disease. Which of the following patient characteristic is most likely indicate poor long-term prognosis?
So,
Hematuria. From what you
so,
told us.
so it is one of the most important high yield point we have missed, that the prognosis is,
Adult onset.
yeah.
Adult, yeah. Adult onset,
So
yes.
most of the disease in nephritic and nephrotic are like minimal change. It is in youngers, right? And it is responding well to steroids. So the age is somehow important in these conditions. And in our this stem in post-streptococcal glomerulonephritis also, the adult onset and comparison between adults and youngers, this affects the prognosis. Okay, so in children the prognosis is good. Okay, but in adults it's poor. Okay, getting this.
Yeah.
Yes.
So you have to
So,
like memorize this point that post streptococcal in youngers, they have good prognosis, they almost recover completely. Okay, in children's. Okay, while in adults the prognosis is poor. Okay.
so, hmm,
Yeah, so let's see what they have written.
also,
So I think we should
the
read
most
this.
whatever.
So
Poor
PSGN, I don't see any high yield points in this except the age. PSGN is
prognosis.
most commonly affect children, okay, and more than
Yeah,
95% recovered completely, okay.
yeah.
Increasing age is most important poor prognostic factor, okay, and only
Uh,
60% resolved completely, and the reminders have hypertension, recurrent proteinuria, renal insufficiency, RPGN, and end stage renal disease. The rest are not that much important in, but no importance in prognosis. Yeah, yeah. Anyone, please?
Which of the following is most likely under cause of the patient's renal disease? A 37-year-old woman comes to the office due to worsening leg swelling, excessively tired and had achy pain in her hands. Temperature is 99, blood pressure 9, pulse BMI is 32, increased physical examination, so 2 plus bilateral pitting edema in the lower extremities. Bilateral finger joints and wrist are mildly swollen and tended to palpation. Cret is 1.8. Urine analysis positive for proteinuria and hematuria. So it starts the nephritic range. Light microscopy samples from a kidney biopsy shows diffuse global endocapillary hypercellularity. Direct
Okay.
immunodemonstrate full house. staining diffuse global granular staining of IgG, IgM, IgA, C1, Q, C3. Electron microscopy shows subendothelial electron dense deposit. Which of the following is most likely underlying cause of this patient renal disease? So it's
So
use
what are what are the findings we have?
full house, actually the staining, and then we also have subendothelial deposits. We have nephritic range of proteinuria, like nephritic with hematuria, and we are leading towards the diffuse proliferative, right?
So
That is common in SLE.
diffuse global endocapillary hypercellularity.
Hypercellularity,
So what is it? DPGN, okay?
diffuse proliferative glomerulonephritis.
And what others? Full house. So full house immunoglobulins are in what condition? DPGN due to
SLE.
SLE,
sleep, right? And what other things you can see? Subendothelial deposits. So it is also the same is PSGN and IgA, okay? So we have an addition. We discussed PSGN, we discussed IgA. We have diffuse proliferative glomerulonephritis. We have immune complexes. Here and here it is subendothelial deposits. Okay, got this? Here,
Yeah.
mesangial was that right? The full house is a classic hallmark for SLE. Okay, we don't see that in something else. Okay, so what's your option? Option E. So I think we should end this. We have done lots of questions today, almost 25, 24. What you guys gonna do is I will send 4 or 5 questions from it, okay, in group.
okay, sir.
So you will have just to quickly go through it. These are easy. And I will look the rest of the question. I will go through it by myself, and if any of them are difficult or need explanation, so almost 8, 9, or 10 question will be remaining. So we can do it on Sunday, okay?
Okay, sir.
And if
Okay.
uh,
Um,
and if the questions are easy, so I think we don't need to do it. Okay.
okay. Will you
So
be having a class
guys.
tomorrow, sir?
Yeah, so today is Friday, right?
Yeah.
So tomorrow we will have a class, okay?
Okay.
So for tomorrow, I think tubulointerstitial diseases, and I will look into the topic. Just go through your schedule, and I was worried that if you guys did not have gone through the nephritic and nephrotic, it will be a big problem for me to teach this, but it was good. You guys have the understanding of this. Okay, any question?
Thank you so much, Dr.
Thank you
Hisham.
so much, sir. Hope you get some rest and feel better.
Yeah, yeah, thank you.
No,
Yeah,
So, sorry if the session was not good.
it was
it
so
was
good.
fantastic. We learned so
Yeah,
much.
Okay,
can be
thank you.
better, I think. Thank you so much.
Oh, thank you so much. Yeah,
Take care.
take care.
Bye. Take care. Bye
Bye.
bye.
Bye
Bye.
bye.
I don't know who's when I was muting. Mm. It's too fast.